welcome and thank you for joining us today on the topic of taking the taboo out of women's gastrointestinal health. My name is Desiree Hughes, and this is Dr. Rachel Weinheimer, and we will be your hosts today. As a reminder, the session is being recorded and will be posted on the Texas Oncology website after the event. Just to kind of go over the agenda, as you may be aware, colorectal cancer is the second leading cancer killer of men and women combined in the U.S. And as you will hear, it's also increasingly being diagnosed among younger adults. Today, Dr. Weinheimer has joined us to present and answer your questions surrounding cancer and all of the topics we don't talk about because we think we're alone in the issue. But rest assured, you're not alone. Many women struggle with the same bottom issues just like you. Dr. Weinheimer will focus today on colorectal cancer screening, prevention, treatment, and gastrointestinal health. We'll begin with an overview of Texas Oncology and Texas Surgical Specialists. Then we'll move on to the colorectal cancer, gastrointestinal specifics, and finally, the most exciting part is your questions at the end. So let me introduce you to Dr. Weinheimer. Dr. Weinheimer, what drew you to the niche of colon and rectal surgery?
Well, first of all, it's a very interesting field. It involves a lot of care that is specific to women. While colon cancer occurs in both men and women, there are many anorectal issues and pelvic floor issues that women need help with, and often it's nice for them to be able to go to a woman physician and have a conversation.
Well, we're glad you did, because sometimes these topics are a little hard to discuss. As you can see on the slide, Texas Oncology's expansive suite of services, leading-edge technology, and commitment to quality care treatment is tailored to each patient's needs. Here in Amarillo, we are able to offer patients a number of services, including medical oncology, gynecological oncology, radiation, hematology. We also offer colonoscopies, screening mammograms, and those are just to name a few of our many services. Okay, so let's get to the topic and why we're all here today, and I'm going to let you take it from here.
Okay, excellent. Well, thank you all for joining me, and I'll just take you through a brief overview of the parts of my practice that I feel are important and the biggest messages that I would like to give to a community, if I can only get 25 minutes of your time. So to start out, I would like to address a few myths that are very common amidst our population. And they're things that we need to discuss because it's important to know the truth. So first of all, women are diagnosed with colorectal cancer more than men. Myth versus reality. Actually, this is a myth. Colon cancer is an equal opportunity offender. It affects men and women equally, and it's the second leading cause of cancer death. Another myth out there is that colorectal cancer is fatal. People say, oh, why should I get screened? Because if I have it and they find it, I'm just going to die anyway. So this is a really nihilistic approach, and it's actually untrue. So if you can catch colorectal cancer early, you have an over 90% chance of being alive at 5 years if you are diagnosed at stage 1 or stage 2 disease. So it is 100% worth getting screened. The next one, it says only people with a family history of colon cancer get it. So I don't need to get screened if no one that I know has had colorectal cancer or none of my family has had. That is another myth. There are a few genetic disorders out there. Lynch syndrome, is one of those genetic disorders that leads to colorectal cancer, but it only accounts for about 3% of the people who develop colorectal cancer. 75% of people out there have absolutely no risk factors whatsoever when they find that they have been diagnosed with this disease. The next question, I only need to be screened if I have symptoms. That is another myth. Many people come in, even younger people in their 30s and 40s, and they actually have no symptoms at the time of their diagnosis. So it's important. As soon as you hit the age where the Cancer Society said, let's get screened, you need to go ahead and get screened. And then finally, diet and weight are important risk factors for colorectal cancer. This actually is a reality. Obesity, having a high-fat, low-fiber diet full of red meats, smoking, and then excessive alcohol use have all been found to be contributors of colorectal cancer. This slide is important important because it just shows the very high incidence of cancer, both within the United States and then especially in Texas. So we have the second most cases of cancer and then the second most cases of colorectal cancer in Texas within all of the United States. So if you look down at the bottom left, you'll see that 11,000 new cases of colorectal cancer are diagnosed in Texas this year, and 4,000 of those will die. You'll see that number in the bottom right. So it's important to get taken care of. This next slide just really highlights that early detection is key. When you detect it early, stage 1, stage 2 disease, then you will be able to have an over 90% 5-year survival rate if you receive all treatment. Now, when we talk about screening, so often I get questions in my office about, why do I really need to get a colonoscopy? I don't want to take off work. I don't want to have to take that nasty prep. And we have to have a little bit of a discussion about what the options are out there. So you've got the FIT test, you have the fecal occult blood test, you have the Cologuard, and then you have the gold standard, which is the colonoscopy. The colonoscopy is undoubtedly the best test, but it also requires a day off work. It requires a ride to the endoscopy center. It requires a bowel purge that some people find very frightening, both before and after the procedure.
Right.
So, but ultimately people do well and then they can get a scope. So let's look at the data on why you should get a colonoscopy. If you look at the numbers that are circled in red, those are the numbers of they're the number of colorectal cancers that will be detected by each of these tests. So if you look under colonoscopy, you're going to see that 95% of colorectal cancers are detected, which is fantastic. I mean, that's a great screening test. The FIT test is okay. The fecal occult blood test is not worth your time. And then the FIT DNA test is actually excellent. It's over 90%. It's coming on strong. That's the Cologuard. That's a great test if you want to make sure that you don't have cancer. The concern is that colorectal cancer is largely preventable, meaning that you have to find polyps, precancerous lesions that are going to turn into cancer if you want to prevent the disease. So you look at adenomas. That's the green line that's circled. Over 90% of adenomas will also be detected on colonoscopy, and you will remove those adenomas at the time. If you go all the way over to the FIT DNA, which is, again, the Cologuard, you're going to see that about 42% of polyps are identified. If we are going to wait until a polyp has turned into cancer, we have waited too long. So that is why I always recommend that my patients undergo colonoscopy. I want them to find those precancerous lesions, and then I want them to be removed so that we can prevent a colon cancer. These are the symptoms. And again, many patients will present without any symptoms, but if you are having abnormal bowel habits, if you're having vomiting, diarrhea, blood in your stool, and then one symptom that always concerns me more than most others is unexplained weight loss. In the United States, with our high-fat, low-fiber diet, it's very difficult to have weight loss that is unintentional. And when patients say that they've been dropping 10, 20, 30 pounds in the last several months and haven't meant to, this is concerning to me. When you do have a colon cancer that is identified, I want to point out that the surgical treatment for this disease has actually improved tremendously over the last 10 to 15 years. So whereas in the past, you would be in the hospital, you'd have a big incision down the middle of your belly, you would have a tube in your nose, you'd have a tube in your bladder, you'd be there for 5 days or 7 days with a pain pump. Now, we can do the operation minimally invasively. What you have before you is a robot, and that allows you to have 4 tiny little port site incisions. They're little keyhole incisions in your belly. You'll go in, you'll have the operation, it'll take a couple hours, and then when you wake up, you'll be on a regular diet, no narcotics, basically Tylenol and ibuprofen, and most of my patients go home the next day. So there have been tremendous advances in colorectal cancer, and it's not quite as scary as it used to be. This is an example of what the incisions used to be. So if you look at the far left, that is the big midline scar that most people would have after a big belly surgery. On the right, what you see are the 4 little keyhole incisions, and that's where the trocars go. You can see that the robot trocars are actually in somebody's belly there. But then you pull them out, you close the tiny little holes, and you move on. The cosmetic outcome is much superior. Now that we've talked about colorectal cancer, that really is only about a third of my practice. So I do want to spend a little bit of time on all of the bottom issues. This is one of the big reasons that I went into colorectal surgery. There are many, many issues that women specifically deal with, and there's just not much knowledge about them. I mean, this is not typical dinner table conversation, and so women deal with these problems for years and years and never have anyone look, and so they never get treated. So all of the problems that you can have, anal pain, bleeding, itching, something's hanging out of my bottom. You ask yourself, well, should I do anything? And sometimes women do go and they seek medical advice, and it's difficult to tell what's going on because it's hard to do a good exam. So when patients come to my office and they say, I'm concerned about a protrusion, the first thing that I would recommend always is get an exam. So if you're having any of these issues, you have to have someone look. But now let's talk about the different things that it could be. If it's a protrusion, a lot of the times, or many times, it could be hemorrhoids. So you ask, what can I do about hemorrhoids? Well, most of the time it's a high fiber diet. You need to minimize time spent on the toilet. You need to drink a lot of water and just have one soft bowel movement a day. When you spend minutes to hours playing Candy Crush on your cell phone or answering all of your emails while sitting on the toilet, that can cause some pretty significant hemorrhoids. And they can cause bleeding. They can cause a protrusion. That being said, hemorrhoids aren't the only thing that cause bleeding. I mean, constipation can also cause a tear in your bottom, in which case that's known as a fissure, in which case you would need completely different medical treatment. So the short message for all bottom issues is that there are certainly things that we can do and that we can offer for bleeding and pain and something hanging out, but it really depends on what the diagnosis is. There are several different diagnoses that it could be, and so get a good exam, and then we can start getting it treated. So there are very good options. And then finally, I want to address fecal incontinence. I think this is super important because this is a highly undertreated condition among many women. For some reason, in our community, it's okay to talk about having to do Kegels because women who have gotten older and who have had babies will leak a little bit of urine, but no one wants to talk about the fact that often they leak stool as well. That's concerning because this is hugely life-limiting for many patients, and often they'll go from one person to many patients won't ever even tell a doctor, but some will go from one doctor to another, and they'll come away with the idea that this is just what happens as we get older. And, yes, there is an element of age-related muscle weakness that comes along with getting older, but there are very good treatments for fecal incontinence. And when patients come to see me, we go through a stepwise approach in which we first start with medical treatment. I mean, we talk about fiber therapy. We talk about pills that can help solidify stool and make sure that they only have solid stool rather than having the patient leak liquid stool. We talk about pelvic floor physical therapy. There are very well-trained, educated physical therapists who know how to rehabilitate a pelvic floor that is weak after, having gotten older. And then finally, there are sacral nerve stimulators that I place pretty regularly. These stimulators will basically innervate or provide extra innervation to your S3 nerve, which is the nerve that helps to maintain control, both for urine and for stool. And when you have that extra stimulation of that nerve, you get some feedback to your brain in which when something goes into your bladder or your rectum, your brain says, maybe I need to start heading to the bathroom. And sometimes it's just that extra 2 to 3 minutes of warning that patients need to have a far, far better lifestyle. So that's an important aspect of my practice as well. Finally, I want to touch on the fact that lifestyle is important. I know that we talk a lot about that, but not being sedentary, getting up, being active, eating a high fiber diet. I know it's terrible to say in Texas, but we do have to limit our consumption of red meat. And then no tobacco and moderation with alcohol. Apart from that, our message today would just be to get screened, and if there are any concerns that you have, come and get an exam so that we can make sure that there's not something dangerous going on. And if there is, we can treat it, but if it's just a concern rather than, if it's something that's benign, often there are very, very good treatments that are available.
Awesome. Okay, good. And then here's your beautiful family.
Yeah.
I just want to thank you. That was very informative. It was interesting. So thank you for that. We have several great questions that have already come in. So I'm going to read through those for you and then let you answer and take it from there. If we do not get to your question today, I do apologize, but you can always visit our website at texasoncology.com to get your answers to your questions. Or if it's more concerning topic, you can always schedule an appointment with Dr. Weinheimer and come in and see her if you're in the Amarillo area. And if you're not, then you can visit our website to see if there's a provider near you, because I know there are several people on this session today that are maybe not in the Amarillo area. So, okay, let's get to the interesting part, and I'm going to kind of read the questions to you.
Okay? Perfect. That sounds perfect.
My cousin was recently diagnosed with a polyp after having a colonoscopy due to abnormal rectal bleeding. She's 32 and will now be followed by a GI specialist for the next 5 years. My mother and her mother are twins. Is this something I need to be concerned about and check for as well?
I would say that if you have polyps in your family, you certainly need to abide by the standard screening guidelines. The American Cancer Society and the American Society of Colorectal Surgery both advocate for screening at age 45. At the very latest, I would advocate for getting screened at age 45. If you yourself have polyps after that, then you should undergo repeat screening every 5 years. That being said, if you've had any first-degree relatives who have an actual cancer, not just a polyp, but an actual cancer, you should get screened 10 years prior to their age at the time of their diagnosis. If not, then 45 will be an okay age for you.
Okay, great. I'm a 48-year-old survivor of triple-negative breast cancer last year. Congratulations, by the way.
Yeah,
that's
absolutely.
exciting. Should I have a colonoscopy this year? And she's 48 now.
Yes. The answer is yes, you should definitely have a colonoscopy. The screening guidelines would recommend starting at age 45, even for patients who have no risk factors, and knowing that you are prone to developing a malignancy, yeah, I would definitely suggest going ahead and getting your screening done.
So get screened.
Yes.
Get screened. As we age, what is the best way to keep our colon and bowel movements regular for women that have issues their whole life?
Okay. Well, most people that come into my clinic say that they struggle with constipation, and that is really a product of our environment as well as our lifestyle. I mean, we have these sedentary lifestyles where we sit at desks, and then we also live in a Western world where we have such a high-fat, low-fiber diet that constipation, is an issue for everyone. It also doesn't help that we live in a very fast-paced, anxiety-provoking world, because sometimes our intestines can manifest some of our stress, in which case many patients then get an intermittent diarrhea and constipation situation and have to take medication for irritable bowel syndrome. So my recommendations would be to lead an active lifestyle, take a fiber supplement, because I don't actually know that anyone is able, very, very few people are able to eat an appropriate amount of fiber in their diet every single day. So I recommend a Metamucil supplement to every patient every day. Apart from that, I know we've talked about it before, but limit consumption of red meat, limit alcohol intake, and don't smoke.
Always going back to live a healthy lifestyle.
Yeah, live a healthy lifestyle.
Okay, so what is the best way to fix fecal incontinence?
Okay, so we talked about that before. When I have patients who come in and they say, I leak, I'm a leaky person, and it has completely changed my life because I can't go to yoga. I have to wear a pad all the time, and I'm terrified to go to the grocery store. I say, this is a problem that has been developing for years. Most of the patients underwent some sort of obstetrical trauma, meaning they had a baby. They pushed a baby out of their pelvis, and that causes long-term nerve and muscular injury. And while the symptoms of fecal incontinence may not manifest themselves immediately, women in their 30s have a very strong pelvic floor. Those symptoms do come up, years later as they develop age-related muscle weakness. So what I tell them is this is a problem that's been developing for decades, and it can't be fixed overnight. So we start with medical therapy. We start with fiber. We start with you having normal, healthy bowel function. And then we work on physical therapy. There are very well-trained physical therapists who can rehabilitate the pelvic floor. And then finally, if they need an extra boost, if they need just a little bit more help, I'll go ahead and implant a sacral nerve stimulator, which can often, it was FDA approved because it decreases symptoms by over 50% in most patients. So every little bit helps, and it can really change someone's life.
Okay, this is going to be our last question. Is Cologuard a good screening option during COVID when getting to and from a colonoscopy appointment is difficult?
Well, at this point, my answer is probably going to be fairly predictable. I would say that there are certain medical treatments during COVID that we may not want to pursue, just because it can be scary to get out there into the community and into a surgery center. That being said, a colonoscopy is not an emergency. It doesn't have to be done right now during this COVID crisis. It does need to be done, though. So if it makes you feel more comfortable to wait 1 year, I would still recommend getting a colonoscopy. It's the gold standard. It is the only test that will take care of problems at the same time that it diagnoses them. If you're too nervous or you can't find a ride to get a colonoscopy, at this time, it's okay to delay a little while. It's okay to delay 6 months, a year, but it's not okay to skip it.
Right.
Has to be done.
So at the end of the day, COVID or no COVID, getting screened
is of the utmost importance.
Is the most important thing out there. And you can also contact our site and ask them what protocols we have in place or what safety features we have so that everybody, you and the person next to you, is all safe during this time. Okay. Thank you all for coming. Thank you, Dr. Weinheimer, for your time.
It was a pleasure.
It was great information. I'm sorry we didn't get to all the questions. There's so many because, this is a topic that we all want to know about. And you're right, we're not talking about it with our neighbors or our book club or whatever. And thank you so much for your time, and we hope you enjoyed it.
Thank you.